Welcome everybody. So good evening to people listening in from India and good morning to America. So in the next 25 minutes, I will give a quick update on the state of cellular therapies for lymphoma. As you all know, the two major diseases for which we do both auto and allo transplants and now cellular therapy with CAR T cells are diffuse large B-cell lymphoma and mantle cell lymphoma. For follicular lymphoma, the transplant activity has gone down quite dramatically, prompted primarily by the new drugs that have come through in the last decade. We'll then talk a little bit about the selected abstracts from the TCT meetings that now seem so far away. It was in February, not that long ago. That was the last major travel that we all had. After that, it's all been shut down. So that's how we will go about it. Going to the next slide. Let me see if I can go. Yeah. So we all know that the primary basis by which we do the autologous transplant for relapsed diffuse large B-cell stands on the Parma study, which was now published almost 25 years ago. And that's a study that showed that autologous transplantation is the treatment of choice for patients relapsing from diffuse large B-cell lymphoma. Just to remind people, in that study, the conditioning therapy used was what we call BIAC, or BCNU, etoposide, Ara-C, and cyclophosphamide with involved field radiation. The most commonly used transplant conditioning regimen for the same autologous transplant for diffuse large B-cell is these days BEAM, where the cyclophosphamide was switched over to melphalan, 140 milligrams per meter square, and no radiation is used. There is another very popular conditioning regimen that's used in the United States. I don't know how popular it's in India, which is CBV, which is very similar principles. So one of the questions that we continually ask, both Sergio and myself are very, very interested in this question, is can we improve conditioning? Because we have not, this is one area where we don't make much improvement. So the BMT CTN several years ago did a study of Rituxan beam versus Bexar beam. Bexar, as you know, is the radioimmunoconjugated antibody. And there was single agent activity in follicular lymphoma. So we added it to the conditioning, hoping that that would improve outcomes. Unfortunately, it was a negative study. Then we recently analyzed in the CIBMTR beam versus Rituxan beam to see if the Rituxan beam is any better than beam. There again, we could not show any major advantage in autologous transplant for adding stuff to beam. With that in mind, at the TCT meetings this year, this is the memorial group, I think, from showing the variability in AUC when we use melphalan. So the bulk of the conditioning, the last day of beam is melphalan, 140 milligrams per meter square. And in the myeloma literature, both of us, Dr. Geralt and myself, are interested in the variability in melphalan exposure when we give the same weight-based or body surface area-based dosing for melphalan. And here again, as you can see, there's a pretty dramatic difference in the exposure of melphalan. But in this study, probably because limited by numbers, the people who got more than median exposure, the only difference was actually in the toxicity, not really in any survival-based outcomes. So there is more coming in this area, I'm pretty sure, because we are now trying to optimize the amount of melphalan we deliver, just like we have optimized busulfan. It took many, many years for busulfan optimization. This is probably going to happen for melphalan. Now let's go to the change in field. This is a time of major change in what we are going to do in terms of cellular therapy for lymphoma. CAR T cells have now been approved most recently. Within the last week, they were also approved for mantle cell lymphoma. They are already approved for ALL, as you know, in young people, diffuse large in various forms, transformed or primary mediastinal, etc. So these CAR T cells are all the first wave of CAR T cells. The agents approved, again, as you all know, are these ones. They are, based on the Zuma study, the agent that we call Axicell or Yescarta for ease of naming it. This is a retroviral transduced CAR T cell director against CD19. And the co-stimulatory domain is this molecule, CD28. Whereas the earlier one, actually, the one that was first published was actually this one, but the approval came a little bit later. It's also known as Kymriah, and this is Tisocell, and the co-stimulatory domain is 41BB. The viral vector that encodes this is a lentiviral vector. And most recently, this is Lisocell, and this is not yet approved, but data were presented at ASTCT meeting, so we'll talk about that. You can see that the progression-free survival rate, or let's look at the overall survival rate. For people with relapsed diffuse large B-cell lymphoma, many of them had prior auto transplant, as you can see. In this population, the overall survival rate at 2 years is about 50% for the one with maximum data, that is the Axicell or Yescarta. For Kymriah, the data is only updated to 1 year, and it's again 50%. For Lisocell, which is also known as the Juno Carpi, it's about 60% at 1 year. So there's not much difference to choose from between the three agents. There are differences in terms of CRS and other toxicities slightly in actual use. We'll talk about that in a second. If you just look at response rates, it's again in the range of 40 to 50% across the board. But we also need to know that in these studies, how the intent to treat population is not what was always studied. When person signs consent, then they have to be enrolled in the study, then they have to collect cells. The cells have to be made into CAR T cells at a different location, and they will be shipped back. So the median time is anywhere between 4 weeks to 5 weeks, and so in some cases even longer. So that means that not everybody who intended to go on study actually got the cells. There's a huge drop-off in the number of patients who actually received it, despite having the intention or the need to get them. The durability among the CAR T cells we just saw, but what I want you to look at is the grade 3 and 4 toxicity, which is the right-hand column here. Grade 3 and 4 CRS, which is cytokine release syndrome, which is this major immune-mediated storm that happens in patients who have actively proliferating CAR T cells in their body, was 18% to 22% across the board. So basically, it's in the 15 to 25% range for all of these agents. And this agent, JCAR017, it is the agent that we saw in the Transcend study. That seems to have a little lower grade 3 and 4 CRS percentage. That's mainly because they modulate the ratio of CD4s and CD8s that are given to the patient. CRES is now known as ICANS, or immune-mediated neurological syndrome. It is the encephalopathy that happens. And again, it goes kind of hand in hand with CRS, but not everybody with CRS gets encephalopathy. And you can also get it after the CRS has subsided. That again is an even worse toxicity because it's sometimes very difficult to get back to normal. There was an analysis presented at ASTCT about the comparison of ZUMA-1 with patients who could not get CAR T. So remember, all the CAR T studies are phase 2 studies. The data only applied to patients who actually got the CAR T cells, not to patients who wanted to go on CAR T cells. So the comparison group is SCHOLAR-1, which is a SCHOLAR study, which is a retrospective analysis of patients with refractory DLBCL in the pre-CAR T era. And it was all first published in Blood in 2017. And now that data set remains as a comparison data set for ZUMA-1 and other CAR T studies. So you can see overall response rates were 72% if you got CAR Ts, 22% if you got other non-CAR T standard of care. CR rates 50% versus 7%. 2-year survival rate, we saw 50% for Yescarta in ZUMA-1 versus 12% for SCHOLAR-1. So CAR Ts have definitely changed the outcome for these patients. And the intent of most patients in ZUMA-1 was to get CAR T, but many patients did not. If you take those patients, that 50% 2-year overall is going to go down to somewhere in the 25 to 30% range. So the degree difference is actually if you were eligible for CAR T with refractory DLBCL and if you managed to get it, not for everyone in that setting, because many people actually die in waiting. Some people don't have enough T cells. Some people have manufacturing failure, and all of those need to be taken into consideration. Now let's look at another aspect, CAR T versus auto transplant, which is where the field is now going. So if you look at the CORAL trial, which is a very informative trial, the primary question was, what is the best salvage therapy? RDHAP versus RGDP, Rituxan GHAP versus GDP. And in that study, one of the things that emerged when analyzed was that the salvage matter in the end, But patients who had prior rituximab-based chemoimmunotherapy induction with CHOP or R-CHOP, for example, if you received Rituxan and you relapsed within 1 year of diagnosis, you actually had a pretty dramatic drop-off. Your prior Rituxan yes patients in the first few months did not actually respond to salvage as well as the people who relapsed more than 1 year after diagnosis. If you relapse more than 1 year after diagnosis, the outcomes was about the same. But if you relapse within a year after diagnosis, after having received R-CHOP, not just CHOP, your salvageability was very low. And most patients actually died. Only 40% of patients actually ended up going to transplant, whereas this drop-off was basically because people could not get to transplant. Now, so then it comes to this question. For a patient who is not responding to salvage, what do you do? And define not responding to salvage. So let's look at a more gray patient. So this is a patient with diffuse large B-cell lymphoma. You can see his PET CT shows a lot of activity. And question is, after salvage, there is clear reduction in activity, but there is definitely residual activity. So this is a sensitive patient. In the olden days, we didn't have anything better to do but auto transplant. We would transplant them. But now we have Carpi. What are you going to do for this patient? So that's the question. And my colleagues at the CIB-MTR tried to answer this question. So they looked at patients who received the first auto transplant, receiving an R-CHOP induction or R-CHOP-like, which means R-EPOCH and things like that. Common conditioning regimens before auto transplant, but sensitive disease. So PR with PET positive, not refractory, mind you. So then they were classified as early failure within 1 year or late failure beyond 1 year. So the progression-free survival, if you look at, or the overall survival, it's again goes back to this thing we see. For early chemoimmunotherapy, failure is bad, but even there, we have a long-term progression-free survival of almost 45-50% if you manage to get to auto transplant. Again, this data set is corrupted by the fact that the failure in this early chemoimmunotherapy failure is actually because they don't get to transplant. If they get to transplant, they're going to be okay. And that has been shown by many studies that we have done before. So overall survival, if you didn't have early chemoimmunotherapy failure, is actually pretty good. It's about 65%. So this, again, indicates that you can actually salvage and possibly cure about 45 to 50% of patients if they can get to a transplant. And that is not particularly different from the CAR-T data that we have seen so far. So here in this area, I think the one thing would be to actually stick to tradition. And unless a randomized study, there are 3 randomized studies going on right now, reads out in favor of one or the other, we stick to what we have already done before. So the questions again remain, CAR-T versus auto for early relapse. So that's the one group we already said are not going to do well. Many people don't get to auto transplant. So maybe we should think about, instead of salvaging them, we should collect T cells early and make the CAR-T so that while they're receiving the first salvage, CAR-Ts can be made. For PET positive sensitive patients that we talked about, and CAR versus Allo transplant. So one thing is clear, after CAR-T got approved in 2017 October, the auto transplant activity in the United States has gone down dramatically. So we were doing 1,200 to 1,400 auto transplants a year for lymphoma or diffuse large B-cell lymphoma, and it has dropped by 50% with CAR-T. Here again is CAR-T activity. As you can see, no CAR-T activity until about 2015, and now that's gone up to about 800 cases. So the missing gap is actually made up by the CAR-T and then some. Allo transplant activity for diffuse large B-cell also has dropped down a touch. As you can see, this is the green line, allo transplant activity, and again, concomitant with CAR-T went down. So allo transplant again in diffuse large B-cell lymphoma, these are studies that we have done before. If you have chemosensitive diffuse large B-cell lymphoma, you cure about 25 to 35% of patients. If you have chemorefractory, you still cure about 20% of patients. And most of us these days do reduced intensity conditioning. But a durable control in these patients with relapsed after auto or primary refractory diffuse large B-cell where auto is not indicated is an unmet need. And CAR-T, as you saw, is about 50% if you look at the patients who actually got it. It is about 25 to 35% if the patients who need it. So this is some data on the CIB-MTR on what has happened. We have not analyzed this for survival yet. So we are looking at about 150 plus CAR-T patients, and most of them are these are post-auto failures. 14 months after auto, they're getting to Carpi. Allo, most patients are about 20 months after auto. You can see that the number of patients with sensitive disease is much higher for Allo. So they're getting salvage and getting Allo, whereas for Carpi, most patients are actually less sensitive, chemosensitive at that point. So we are going to analyze this data, and that'll be there. There is a position statement that came up from the CIBMTR and EBMT recently on what is the role of allo transplant in the future. So one of the areas is in regions where CAR T cell is not readily available or readily accessible for patients. Patients who have persistent disease or who are MRD positive or who have a PR after CAR T, those patients are almost always going to relapse. Your PR can improve up to about 3 months, but after that you're still in a PR. You need to consolidate that with something else, and allo transplant is a readily available tool. Actually, in my practice, I would say that in the last 6 months or so, I'm seeing a lot more patients who are CAR T failures. Patients with poor marrow reserve, obviously, who will need more treatment in the future, you can fix that problem by a reduced intensity allo. Patients who are getting MDS or some other myeloid disorder, and patients who have manufacturing failure for CAR T, patients who relapse with a CD19 negative clone. So that's one of the important CD19 CAR T. So in relapse refractory BALL, as you can see, with the arrival of CAR T, this question became much more prominent. Should we proceed to allo in patients who actually have a response to CAR T, whether a complete response? And so this consideration is much stronger. This question is actively being debated, and while it looks like in children you may not need to, a lot of adults are getting consolidated with allo transplant in refractory ALL that gets into a CR from CAR T. In BNHL, that question has not been asked so far, or at least been not prominent so far, but these patients have a much significant rate of relapse and progression, and we really need to consider this as an option. But for allo to take over, we need to reduce non-relapse mortality, and that, especially in the post-CAR T world, we really definitely need to reduce that, because we are competing against a modality which has very limited non-relapse mortality. So if you look at 4-year non-relapse mortality for various conditionings that we do, the flu-mel 140 stands out, and that is actually one of the conditioning regimens that many people use. And we actually, I do use a lot of mel in allo conditioning because of my myeloma background, but I nowadays reduce it to flu-mel 100 and flu-cy TBI, flu-bu, flu-cy, all of them have a much lower non-relapse mortality rate in the 15% range. Remember, this is not all transplant related. We cover all non-relapse death as non-relapse mortality. So it's not like transplant itself is the cause. It could be other things too. But overall survival is actually pretty good for 4-year overall survival for refractory diffuse large B-cell lymphoma transplanted in the real world. This is CIBMTR data. As you can see, you can cure these patients, especially if they have chemosensitive disease at the time of allo transplant. So that makes it very important that if you're thinking about CAR T failures to transplant, don't wait for florid failure. You can do it for PR, you can do it for early relapse, etc. Now let's quickly go to mantle cell lymphoma. So here's a patient with mantle cell lymphoma, stage 4 mantle cell lymphoma, got auto-transplanted in 2016. Then he relapsed 2 years later, started ibrutinib ixazomib on trial, and after 18 cycles, he's relapsing again. At this time, he's age 69, ECOG is 1. What would you do next? So as I just said at the beginning, CAR T for Allo has just been approved in the United States, and one option would be CAR T. But if you look at poor risk mantle cell mantle cell lymphoma at relapse, 2 years is the cutoff point. If you relapse within 2 years, we call it a 24-month relapse. Median overall survival is only 22 months. For relapse beyond 2 years, it's actually 10 years. So it's a pretty dramatic difference on transplant for mantle cell lymphoma based on when you relapse. The other big time issue is ibrutinib failure. If you have a BTK inhibitor such as ibrutinib, and there are a couple of others now, zanubrutinib, acalabrutinib, if your median post-relapse overall survival in BTK refractory patients is 5 months, that's actually very dramatically low too. So some of the points is, another important basic point is that allo transplant has really good, meaningful immune effect in mantle cell lymphoma. This is a paper from almost 5 years ago. If you look at allo transplant in CR1, overall survival, there is a clear-cut plateau. This is as definitive of a cure as anything else. But it depends on the time when you do it. If you have late allo transplant after multiple relapses, you're not curing as many patients. The curability goes down by about 20 percentage points. Again, early allo transplant, you have basically a flat line of relapse. The relapse number is about 10% and stays there. Again, with CAR-T, as you can see, allo activity in mantle cell lymphoma has gone down dramatically. As you can see here, the number of patients getting allo transplanted were about 120 in about 10 years ago, down to about 50 patients per year. And that correlates with the number of agents we are getting. So this new drug, KTX19, which is a CAR-T, nowadays the trade name is Takartus. This was just approved in the United States for mantle cell lymphoma. It's a slightly modified production method in terms of T-cell separation and T-cell activation using beads and then produced. It's the same construct as the Yescarta kite construct. So this was published in NEJM and presented at ASTCT by Michael Wang from MD Anderson. So they treated about 70 patients, and this is the important thing, 100% BTK inhibitor exposed, 70% BTK inhibitor refractory. As you can see, that's a really bad population. Median overall survival is about 5 months for those patients, and high TP53 mutation rate, Ki67 proliferation index high was 70%, etc. Overall response rate 93% with 67% CR. That's dramatically effective. Grade 3 CRS is about 15%. As we saw, that number is about 15 to 25 for that particular brand of CAR-Ts. Neurological events grade 3 and above, 31%. These are serious events, but again, the non-relapse mortality is actually low. And here is the overall survival and progression-free survival curves. Is again, you can see that the PFS curve is pretty stable after about 14 months, very consistent with the immune effect hypothesis in mantle cell. So you can actually cure people with an immune process. So now comparing these two, allo transplant versus engineered cell therapy, immune effects are about the same. Salvage therapy, we need it in allo. CAR-T, you don't need it. You can just go straight to CAR-T. Long-term overall survival, we are curing about 50% with allo transplant. CAR-T, we don't know long-term because the numbers are quite small. Chronic GVHD is our problem. CRS is their problem. Cost, much cheaper for allo. CAR-T is much, much more expensive. Standard of care availability is very true for allo, but it's not standard of care across the world for CAR-T. And they're not mutually exclusive. That's the most important point I would like to make. We are not competing against CAR-T. We actually need to consider it as a complementary therapy. So one of the things would be to look at the high-risk features in patients with relapsed mantle cell lymphoma and use targeted therapy. Is there a targeted therapy available? Basically, there are TP53 mutation drugs coming, BTK refractory drugs coming like Loxo. And if none of those are available or studies are not available, consider immune effector cell therapy, either CAR-T or allo transplant. When there is available trial or commercially approved CAR-T in your country, in patients who cannot tolerate an allo, you would consider CAR-T. For allo transplant patients many of these patients have MDS developing. Patients sometimes have clonal hematopoiesis outside of MDS. Patients with P53 mutation, all of them we could consider for allo. And also, this is switchable. You could do an allo and you can do one of these. I have, and Sergio have done many CAR-Ts in patients who are post-allo. Those patients are typically not taken into trials, but they're excellent population to do a CAR-T after, because what you're getting is donor origin T cells that have been collected from a patient. So basically, it is collected from the recipient, but it's donor origin. Finally, in conclusion, I just would like to say a couple of points. These are some of the abstracts that were presented at TCT. One of this, if you have a prior CD19 targeted drug, does the efficacy of CAR T cells go down? Right now, we don't have data that it does. So there are many CD19 targeting drugs, some in development, some already approved. Blinatumomab is a classic example. We've all done CAR-T in patients who are BLIN failures, and they do respond. So this is for tafasitamab, which is an ADC against CD19. And again, even in the presence of tafasitamab, CAR-T seems to be effective in vitro. These are some of the data on biomarkers of CAR-T success. So CRP levels and angiopoietin are associated with neurotoxicity. So angiopoietin is basically a vascular leak protein, and that seems to be associated with neurotoxicity particularly. This is interesting data for all of us. This is real-world commercial success of Carpi. After approval, this is CIV-MTR data looking at Carpis done outside of clinical trials. So out of about 250 patients who were pherased, 2/3 of them got Axicell or Yescarta, 1/3 got Kymriah, which is the Atezolizumab or the Novartis product with 4-1BB. This is the CD28. So about 10%, 8 to 10% are dying before the product. Day 90 overall response rate was about 50% with 39% CR. So if you do get it, you do respond just like the study says. But this is the population. And again, in this time period, in the real world early access, a lot of people could not get on because of insurance or other reasons in the United States. Tocilizumab use has gone up quite dramatically, but that does not seem to impair the response of CAR-Ts. And about 2/3 of the patients are now getting Toci with the Yescarta product, and slightly less in, actually 13% in Atezolizumab. Kymriah is slightly less, as we saw in the CRS slides. This again is the CRS and ICANS, which are the major toxicity. So Max Dopp in Germany did this study where they gave preemptive tocilizumab and steroids at grade 1 level. Normally we treated grade 2 or above, and he showed that even when you give it early for both steroids or Toci, the CAR-T AUC does not go down by much. It's just identical, in fact, slightly better for the patients who got early Toci. So this is, again, very refreshing data in that the CRS rates can be brought down by early intervention, and that doesn't seem to improve responses. This is the duration of response curve. Finally, we did mention this agent before, so I'm not going to talk about it. A couple of points. One more point. This is CAR-T failure in CLL. So essentially, CLL is an agent, is a disease which is CD19 positive disease where CAR-Ts have not been as successful as before. And one of the reasons may be that there are these extracellular vesicles, which are exosomes, which are budded off the cell surface. And there is some data emerging that these EVs, or extracellular vesicles, can impair donor CAR-T antigen-specific proliferation and cause T-cell exhaustion. So one of the strategies may be to activate the T-cells using other agents concomitantly given. CAR after CAR, a second infusion of CAR T-cells is something that we have done quite a bit in the United States. It seems like second infusions produced at the time of the first collection are the ones that are being used. A second collection, pheresis, and a second manufacture are almost always failing. Even if you make the product, you don't actually have great responses. That's it. Thank you.